you very much. So thank you for this opportunity to tell you a little bit about the project that has been funded by the NRF, which is about neural signals that drive glioblastoma recurrence. I'm not going to go into glioblastoma as clinical outlook because I think Adam already gave a bit of an intro there. But there's just two things to remember. One, that it's infiltrative, so it's impossible to remove all cells with surgery. And two, that it's very variable. And so lots of different cell types, as you have seen, so it's not very easy to target them all at once. Glioblastoma used to be known as glioblastoma multiforme because doctors would look under the microscope and see that different parts of the tumor just look completely different in different regions. And now with modern technology, we can actually know why that is. Basically, glioblastoma is made of lots of different cell types. And what we have found is that those cell types are localized in different regions. So the center of the tumor looks different from the border of the tumor, which looks different to a place that is close to a blood vessel, for example. And this means that each of these cells responds differently to treatment. And this is one of the reasons that it's so hard to find a universal treatment that works for all glioblastoma cells. So why is recurrence inevitable? After surgery removes most of the tumor, it can't remove all because there's infiltrating cells. The patient then undergoes chemotherapy and radiotherapy, but unfortunately, not all cells are killed, and recurrence comes back, and often very close to the margin, the tumor comes back. So what is the objective of this project? Let's look at these cells. Let's look at these cells that are left over after surgery and that resist the chemotherapy and the radiotherapy. So we've looked into these cells, and remember there's different types of cell types, so we're like, okay, what cell type are these leftover cells? And what we found is that they look a lot like neurons. Like the neurons of the brain, they look a lot like them. And not only do they look like, they can almost act like them. Neurons connect to other neurons through something called synapses. We have found, and other groups have found and published, that tumor cells can also interact with normal neuron cells in this synaptic connection. And what is interesting is that in neurons, these synapses improves basically their survival and makes them proliferate more and basically encourages that kind of line and that kind of survival mechanism. So basically these tumors are taking advantage of these neuronal pathways to promote their own survival. So in order to study this, we're looking into two different models. So for this first one, it is a lot thanks to the neurosurgeons at both the Royal Adelaide Hospital and Flinders Medical Center. And we work with a model called glioblastoma organoids, in which from the tumor, we take little pieces of tumor and grow them in a way that they have all those different cell types and still the architecture that is found in the tumor. However, now we are expanded on that model and are taking not only from the tumor center, but also from the edge of the tumor, where instead of having lots of tumoral cells that come from the center, we take from the border where we have just a few infiltrating tumor cells. So this gives us an idea of that population that is impossible to target with surgery. And rather, this is a population we want to target with chemotherapy or radiotherapy. And we have found that, yes, this environment looks very different. In fact, here you can see some neurons with their prolongations. It's very different from the tumor core. And these have different vulnerabilities, different resistances to therapy. So using this model, we can test the population we want to target. However, we also want, in the lab, to create a model that basically imitates the same area. To do that, we're working with something called brain organoids. Brain organoids are basically a little bit of brain tissue that we create from stem cells that imitates the normal brain. And what we do is we grab these tumor organoids, we put them together, and these tumor cells infiltrate into this brain organoid the same way the tumor infiltrates into the normal brain. And then we can look at these cells and see what they look like, how they respond to therapy, and how to target them. We can then cut off the tumor to imitate what happens with surgical resection, and then follow those cells as they go and create a new tumor, basically recreating the recurrence event. Here we see an example of the tumor mass and the infiltrating tumor cells into this brain organoid. Now, this will allow us not only to see the specifics of this, but also how they interact with neurons, the synapses that I had mentioned before, and how they can take advantage of this to promote their own survival. So these are different things we can see, how they respond to chemotherapy, radiotherapy, and how they then create a new tumor. Because something that is very important is that when a new tumor is found on recurrence, it has, once again, all the variability of the original tumor. Now, because we're interested in the synaptic collaborating with some neuroscientists from the University of Queensland who don't study cancer, rather they study epilepsy, and they study how different parts of the brain connect synaptically to each other. And we're taking advantage of their model where they use different brain organoids to see how these connect, but we're putting it with our own glioblastoma organoids to see how these neural connections between tumor and neuron develop. We can put them on something called a multi-electrode array and see how these electrical connections occur, happen, and how they push the tumors towards survival and infiltration. Not only do they give us this platform, but they're also teaching us how to make very synaptically active brain organoids and how to interfere. Because if we can interfere in the synaptic connections, we can take away some of the strategies that these tumor cells use to survive in this environment. And we can test drugs. Drugs that target the brain and synapses, there's thousands of them, and all of them have already been approved. So if we can use some of these drugs to target tumor, it's like a very quick shift into the clinics. So this has been funded by different NRF grants. It's particularly this NRF research grant was in Memory of Phil Matalone. And we're using this to characterize infiltrating tumor cells, establish this glioblastoma brain organoid model, and then to test how these cells survive the temozolomide treatment, for example, the radiation treatment, and found out how we can actually target them. Specifically, now we're seeing how they use these neuron connections with neurons to survive, but all of these models gives us like lots of strategies to be able to test different approaches. Also, I want to thank the Chris Adams Research Grant, which allows us to set up this collaboration with neuroscientists and bring all of this expertise here to the CCB to continue using this more neuroscience expertise in brain cancer, and eventually to share our results at the Australasian Neuroscience Society. So I want to start with the funding, especially the research grants in Memory of Phil Matalone and the Chris Adams Research Grant, which allowed us to get started on this project and start investigating the cells, but also all of our lab group and collaborators here at the CCB, University of Queensland, and the neurosurgical unit, without who it would have been impossible to get at this material to study this niche, this infiltrating space. And a final very special thanks to all patients and their families who are the reason that we are doing this.
Any questions for Olivia? I guess that you summed it up perfectly. This is a perfect example of how scientists can work closely with our neurosurgical colleagues, and without that close interaction, this type of work would not be possible. So that pretty much carries through with every project that we've presented today. Really, that the scientists doing the bench research, but really having those key interactions with the clinicians that are having that public-facing interactions. Yes, it's a question.
I just wanted to ask, I know it's always difficult, but with timeframes, if you've seen positive results in the research, you were saying it's quite quick because there's some clinically approved
Yes, if we can find drugs, most of the drugs have already been approved for use in brain. In fact, there has already been an accidental discovery when patients with brain tumors often have seizures, so they take some anti-seizure medication. People have already found accidentally that people who took that anti-seizure medication actually had better prognosis of glioblastoma. And now going back, we know why. Now seeing these connections, we know why, because this is survival. So now it's basically let's go on purpose to go find those drugs that do this optimally, rather than accidentally found one that we were lucky. Yes, if we find a drug that we show an effect in vitro and that has already been approved and is used, I can't talk about a specific time frame, but it is much easier, very quick, to get it into maybe a clinical trial because it has already been approved for safety, and because generally glioblastoma very often, many of these drugs, which are also anti-seizure drugs often, are already given.
All right, thanks Olivia. Just jump in.